Nancy. Good morning. I was just teasing some of the gentlemen over here. I'm like, do you guys have school? It's awesome. They said they're on internal medicine. I'm like, how do you get out of it? Like, who does your H&Ps? Don't you have assigned, you know what I mean, numbers every day? I recall a lot of horror things about medical school, but really, I really did enjoy it. Well, I've been a neurosurgeon now going on my 17th year, and I did an osteopathic residency at Garden City through the Michigan State Consortium, and I graduated just after 2001, I guess. And I've been doing general neurosurgery for the entire time, and 6 years ago, I started doing deep brain stimulation also. So I do brain tumors, spine surgery. As you can imagine, spine surgery is very common, and so that makes up the bulk of most of my practice. I do a lot of brain tumors and things like that because I got involved with our cancer committees at our hospitals. And of course, the deep brain stimulation, we can do a talk about that sometime, or Saturday. I know you guys have a big program. I am going to talk about deep brain stimulation tomorrow, Saturday at 5:15. I assume it'll be no one there, but you may certainly attend if you wish, but you don't have to. It's Saturday night. So today I wanted to talk a little bit about kind of some technical things. A lot of times we talk to students and residents about life and how to achieve certain things or meet certain goals, but today I thought I'd just talk about work. We do a lot of implants in humans, probably too many, but what's gone on is as technology has advanced, there's many more opportunities to treat patients and to do a good job, and surgeons are really anxious for patient-specific implants to be available. Right now, we often begin a surgery and we know we're going to have to choose some kind of an implant for the person, and there's just, many of them in the room, or they're in packages and opened individually when we choose a size. So generally they're made to different sizes, and we always wonder, oh, that comes in a 14 and a 16. It would have been so nice to have a 17. There's different situations like that. And so as surgeons, we want the implants and everything to go as well as possible for the patient, because I always say the number one thing about putting something in someone is that the body doesn't want foreign objects. The body's going to try to get rid of it. So if you're going to put it in, you want it to fit as well as it possibly can, and to be integrated if possible. So my disclosures today are that I do have consulting agreements with Stryker, Mallinckrodt, and the Medicines Company. Stryker has let me use some of these slides. I haven't been paid to use these slides. Stryker happens to be a company that's been very open with their 3D printing technology, and so it's really the best slides I could get about that kind of thing. But certainly I'm not being compensated. So neurosurgeons, we treat a lot of degenerative disc disease. We see a lot of backs that frankly they're bad backs. They're just not good. The people are not healthy. Their spine isn't healthy. Sometimes it's from some doing of their own. Sometimes it's bad luck. Sometimes it's just age-related, work-related. So on this slide, what we can see is there is degenerative disc disease here. This disc is not like the others. It's kind of Sesame Street-ish, really. This one's different. And you can see at the disc level, in the disc space, it's different. So sometimes we're gonna face a situation like this in which a patient has gone through some type of a treatment program, and that can be a whole other series of lectures about how you treat this kind of problem. But today we'll skip ahead and we'll say today we're imagining patients that simply need surgery of this kind. So what is a lumbar interbody fusion? Lumbar, meaning lower lumbar spine, or upper, L1 to S1. We don't generally fuse S1 to S2 or 2 to 3 to 4 to 5. As you know, generally S1 to 5 are usually one bone. There may be a residual disc space at S1, 2. It's not generally fused in any way, unless there's a terrible fracture, and that would usually be accompanied by pelvic fractures, which would require enough bed rest that the sacrum down that low would probably not be treated, except conservatively. So lumbar interbody fusion is if we see a patient in which a disc space is collapsed, then we know that on each side, the space where the nerves would travel outward through the neural foramen, which is made up of the superior facet and the inferior facet, this hole would be smaller. If you take something this tall And the support structure in front of it, take a round object and the support structure in front of it, like the disc, gets flatter, well then the hole would get flatter, and that would pinch the nerve. So a lot of times if a person has a pinched nerve, that's what we're talking about. It simply used to have this much room in the foramen, often it's shaped like a keyhole actually, and now they have this much room. So what we talk about is how can we help the person? Well, we want to make the disc space back up to the height, possibly, that it used to be, or it should be. And we'd also want, if we put something in there, we'd want it to move, if we could, like an artificial disc. But if we have degenerative arthritis all around it, that's not appropriate. We'd want to put something in that would help the patient fuse, in the hope that once this area doesn't move, it would have less pain. That is not always true in the spine or other parts of the body, but often in the lumbar region, this can help the patients. So this is a picture, these x-rays here, they show, this is an example of a titanium, and I chose this so you can see it pretty well. This is in the disc space that used to be present. All the disc was removed with a curette, sharp curette instrument, and pituitary rongeurs, which are little pickers. And this was all done from the back. So then we have this big opening for the nerves to travel out. And of course, in this picture, this is a lateral view. This would be, the nerves would be coming out towards you and away from you. And then often when we do interbody fusion, we have removed enough of the facet joints on either side, or one side total, and some on the other, but over a third on each side generally would be unstable. So you would want to back that up with pedicle screws that go in. These go in from the back, and the rods. So this interbody fusion is something that we want to try to do better and better. Everybody doesn't need screws. Everybody doesn't need interbody fusion. But in the people that do, we want this to be better because we're trying to restore lordosis. We wish this part of the cage was taller and this was shorter. But then when you put it in from the back, that's hard to do. You'd have to, jam it open somehow or pry it open and get something bigger in the front, but then somehow get it tighter. And that's one thing we do with our screws is we can distract or retract, we can tighten it down so that the bone above and below our interbody device is pinched down tight because we need contact for fusion. And over here, this is a view where they've done a cage on this side at this level, this side at this level, and probably taken out all the disc space and packed this with some bone material, and then the screws a level above, between, and below. So this is another picture, and this is an example that lumbar interbody fusion can be performed. Oh my goodness, there's a typo, I'm sorry about that. Can be performed anteriorly or posteriorly. And the previous slide, posterior was the approach, meaning through the back. Cut down a midline incision or through multiple stab wound incisions, and then a smaller section, a small incision where the interbody fusion is going to be performed. This particular situation right here, this was performed anteriorly. So on this x-ray, you can see these little dots are the front and the back of a cage made of hard plastic material called PEEK, P-E-E-K, all in capital letters. It's a huge long name of a type of plastic. And then this was, so the whole disc space, so through the abdomen, all this material was removed, this implant was put in place, and then this plate and these screws were put into place. This person would probably be braced also as well for 6 to 8 weeks. So this is another situation where you can re-achieve, and a lot of people do like this if it's possible to do this anteriorly because you could restore that lordosis. That cage can be bigger in the front. Of course, that means it also could spit back out. If you put the plate on, then maybe you could limit your chances of that. So lumbar interbody fusion, we started using titanium, we've used plastic, which is the PEEK. There's a lot of different materials, but you need something with a substrate or substance to it. You can put bone, you can buy bone to put in the space. There's all different things you can do, but titanium was something we started using in the space back in 1988, and the purpose is to provide a bone implant. So between the bone and implant, we need a good surface that's stable, meaning the bone doesn't, sink down on it, and that has to do with how you prepare the end plates. of course, and acts as a scaffold for the bony fusion to occur through it. If you're going to have a lumbar interbody fusion at L4-5, you want 4 and 5 to fuse through the middle, through the portions of the body that used to have disc space separating them. So titanium was studied since the 60s. Originally, knees were made of titanium, the artificial knees. And titanium has a good bone to implant contact, and it can be a very, very good source of anchoring, and bone tends to attach to it. So the stimulation of the human osteoblasts and the rough surfaces of the titanium were discovered to promote this even more. So then we said, what is the next material we can do to stimulate this even further? So what we want to do in lumbar interbody fusion is we want maximal contact. So if you're at the back of the disc space here and you take out all this disc material, then you want to put your cages in. That's what, we usually refer to them as cages, even if they're not cages. And if they are cages, what we're saying is some of them are metal, and there's spaces, so you can pack bony material and allograft material into this space to help the bone grow through it, to stimulate more growth. So this is the goal. So what we're trying to achieve is reliably and perfectly reproduce this strong scaffold, and we want a sticky surface. We want human osteoblasts to reproduce and just love being there. So we found out tantalum would work too. So back in around 2000, and then by 2003, we could buy tantalum devices, and this is trabecular metal. And if you think of the word trabeculae, it means, has holes or a lattice of some type, and that's exactly what it looks like. This happens to be a cervical interbody device, but they make lumbar ones in all different, and a bunch of different shapes. But these little holes, the bone actually grows into them. And it goes through the middle. We usually put some allograft in the middle, but you don't have to. If you use a PEEK cage, it's not integrated. The bone will grow through it, but the PEEK cage will always exist separately. We always used to say, after nuclear holocaust, there's going to be cockroaches and PEEK cages everywhere, because it won't melt. It won't. I don't think it'll melt. I mean, all the titanium and tantalum, all that'll probably go away. But yeah, I think PEEK cages will still be around. So the various porous materials that are being created all over the world, lots of them in Germany, they are beginning to use additive manufacturing, or AM. You may know about this as 3D printing. But if you wanted to make something with a scaffold or lattice, the way you could do it over and over and over, and you could make it the same, or you could alter it, it seems like additive manufacturing, lay down one layer after the other. Would be a good way to do it. So these are just some of the kinds available. This is titanium, this is the trabecular metal, and again, this is not made with 3D printing. This is the regular tantalum I just showed you. It's been available since about 2000. And then the tritanium, this is new, and this is made with additive manufacturing, as is this. And then this is just just a sample company that, this is what it looks like. It is FDA approved to use 3D printed interbody fusion devices. So when you're going to do 3D printing and you want to make a porous metal object, the computer would just instruct the laser that's going to lay down each layer of the carbon fiber, the titanium, the tantalum, whatever your metal is, and then it's going to make them over and over and over in sheets, or you can tell the computer to make one. So this makes us feel hopeful that we could be on the way to ordering patient-specific. What if we could look at their MRI and their CAT scan, and we could say, I want something that is not a 16 or a 17. When they're standing, I can tell I need a 16.5. If we could get more exact. And I just use those kind of numbers as examples. So the computer planning is what makes it really exciting to us, because you could do this over and over. You could make it very specific, and you'd probably make it very expensive. So this is a tritanium implant, lumbar interbody fusion. Usually we put 2 in. They don't really come in pink, but I just made that pink. That'd be cool though. So generally, this would be the end from the back that you put in first, so it's kind of tapered, so you could get it into the space. And then This part right here would be, it's very, very, very sticky. You can see it's rough, and then this is the smooth side. So you want your smooth side laterally immediately, so when you're putting that inner body cage in and retracting a nerve root out of the way, at least your smoothest side is by your nerve root, because you don't want to catch your nerve roots. And I generally do this completely by myself, and maybe my assistant can hold a sucker, or I have nerve root retractors held by someone else if I'm letting someone help me. Because a nerve root, you can really shred it with a cage, as you can imagine. So this is one example. And then if you talk about additive manufacturing or 3D printing, this particular kind is the laser rapid manufacturing. The focused laser beam, melts the layers of metal powder on the fusion bed. They make this big, metal tray. That's kind of what it looks like, and it just kind of makes it look like they formed the cages right out of it. There are 2 pictures that are proprietary of this that they won't let us use, but it is pretty cool. It just looks like it's, one is this tall because it's just starting, and then the rest are, down the page. It's pretty cool. So we look forward to having a lot more implant choices. Stryker already has the titanium knee that came out in 2013, and now this titanium material is being allowed to be used on the inner body fusion devices in the lumbar spine. And what kind of makes this special, and this is not to sell you a Stryker implant, this is just to let you know, it's got a smooth side and it has nice applicators that make it safe to put it in. Because if you're going to hurt the person's neurologic structures, what point is a lumbar fusion? If they're going to leave with permanent loss of the L4 nerve roots function, this didn't go that well. People have to walk and need a quadricep usually to walk. So the neat thing about this is they can choose the pore size, they can choose all kinds of things about it, and they have gone ahead and made it in various sizes ahead of time. We won't be able to order it per patient or anything yet, because it's going to be very expensive. But at least they've made it available so we can use it, and they, of course, would like to make more money for this expensive product, but most hospitals, that's not how it works at all. Whatever I would choose to use for an interbody device, the hospital's already decided, no matter which one I use, what they're going to pay. So if a company, let's say Zimmer or Biomed or somebody wants to bring something in, they'll have to sell me that screw for the same price as every screw. Any screw we use at the hospital, if it's $200, it's $200. So, to use these titanium cages, the reps would have to agree to the same price. So it's kind of a thing I'm sure you'll hear more about that if you're on rotations. I'm sure you see orthopedic surgeons or even general surgeons, various meshes. On the brain, we have various dural implants. How much does this one cost? Does this one have to be sewn? Can we stock it, or does the rep have to come? There's a lot of things like that go into all kinds of implants that you may not know about. So it's kind of neat because all these cages, they look random. They're completely not random. They're very interesting. They're virtually identical. So this allows the complex porous structure to be made, and it is probably the strongest structure that we can make by laying it down layer by layer like this. I think there's a lot of potential applications in the future. I was thinking it'd be good for artificial elbows too. It seemed like, if the titanium knee works, it seems like in the arm. The arm is asked to do a lot more than the knee in terms of you've got the 2 forearm bones and the humerus, but I think that could be pretty interesting. So what we wanted to show is that when you have a porous metal, tantalum or this titanium, what's kind of neat is at 8 weeks, this is portions of inside the sheep. The sheep has been sacrificed. Inside the sheep here, you can see portions of the cage. You can see this is at 8 weeks bony growth all the way across already. It's amazing. But it's just not when I went into practice, we used bone. We had some cages made of PEEK and some little cages made of, I don't even know what, coral. Lots of hard sclerotic stuff, things that were kind of, I think of it like, breakable like glass. Those are the kind of choices we had. And so to me, to see something like this at 8 weeks, obviously osteoblasts love this. And we could go over the extremely awesome cascade of everything that happens in bony fusion, except that I don't hate you, so we don't have to do it right now. but I love it. It is awesome. So the future, I mean, I think it's unlimited. I'm sure you can think of more applications than I can, but additive manufacturing, there's going to be a lot of applications, I think, in medicine and well, in everything. You always want to ask yourself, just because you can, should you? You know, and that's a hard problem. You know, if it really is safe enough, just as safe, just as as good of a fusion as you expect to get, um, should we just use what we have, or should we go through what we need to go through? Because it can be a very big deal to bring a new product into your hospital. I don't know if you've seen surgeons struggle with that, or other, I'm sure cardiologists, hospitalists, everybody is struggling to try to bring in the latest and greatest, but money is a huge problem. So sometimes you can't get what you wish your patient could have. So when the answer is yes, that you should do it, how can we make it affordable? And these are some of the huge challenges that lots of smart people, I know that it sounds weird, but there are some smart people that run big hospital systems, and there are some really smart people that run big insurance companies. But how can we make this accessible? Because, as doctors, we feel like we're just standing there begging, can we please have it? Can we please have the thing? And some people, I think they think that doctors, we want the latest, greatest thing. They may not realize that we want it for the patient. We want it for success for the patient. I really don't, it really doesn't matter to me which implant. And then there's always, greed. There are a few bad eggs in every, set of apples, I guess. But it's a situation in which you don't want to do too much, but you want to do enough. So that's all I really wanted to show you. So now we can talk about anything. It's kind of cool. I think there's